So without further ado, Dr. Bell.
Jennifer. Yeah, I used to work at UTMB. So I was here at UTMB, left in 2005, and I was working in the TDC and the Free World clinics. So I really enjoy the opportunity to come back. I know some people, as I said, I used to see patients and when people would come to Hospital Galveston and also on telemedicine. So I appreciate the invitation back. The topic of my talk is cardiovascular disease and HIV. They also asked me to speak about smoking and retention to HIV care, which is kind of a lot of things. So I hope to give you some highlights and educate you about these topics. I went to the Food and Drug Administration about 1.5 years ago, and I work at getting antivirals approved, which include HIV medications. And I'm so glad you guys still provide quality care to HIV-infected patients. I wanted to add, this is a obligatory slide for my presentation. These views are my views and not the views of the policies and practices of the FDA. So outline of what I'll be talking about in this hour lunch and learn is to describe contributions to increased cardiovascular risk in HIV disease, and it's in part related to comorbidities that HIV patients are known to have in this day and age. I'll talk about dyslipidemia. I'll be also discussing the drugs for HIV and how they contribute to cardiovascular risk. I will be giving some clues into the pathophysiology of increased cardiovascular risk. I will be showing you techniques to evaluate atherosclerosis and the data that they've produced to show that HIV patients have increased cardiovascular risk. And I'll be touching on trials in smoking cessations in HIV-infected patients and also retention to care strategies. So I wanted to start with the case of a patient I had at Thomas Street, and I worked at Thomas Street Health Center in Houston for 10 years. So this was a 55-year-old African-American male with a history of HIV, prostatic hypertrophy, hypertension, and asthma. He had a history of HIV since '97, had been on multiple HIV regimens, had PJP, PCP in the past, shingles, and he also had the comorbidity of psychosis. And as you know, a lot of our HIV-infected patients also have psychiatric comorbidities, which are sometimes challenging. He was on 3 medications for his high blood pressure. He was on darunavir 600 milligrams POBID and ritonavir 100 milligrams POBID. He was on tenofovir, emtricitabine, or Truvada, 1 tab daily. Social history, he moved from Houston to Houston from El Paso in 2008. He wasn't a smoker. He didn't have any family history of coronary artery disease. On physical exam, he was normotensive. His heart was fine. His prostate exam was a little enlarged, but no masses. And he had a CD4 count of 271. His CD4 nadir was actually, when he saw me at Thomas Street in 2008, of 125, 6%. He was undetectable on his HIV viral load. His creatinine was mildly elevated, 1.4, but his GFR was within good range. His cholesterol was 201, his LDL was 140, his HDL was 26, and his triglycerides were normal. And at that time in 2008, we had the Framingham risk score to help characterize HIV. And by Framingham risk score, he'd be 10%. Intermediate risk is 10% to 20%, so he'd be intermediate risk. And if he was a smoker, he'd be high risk with a Framingham risk score of 25%. And in this day and age, they use the ACC-AHA risk calculator to decide if patients need statins. So that changed in 2004. So his risk calculator puts him at 11.6%, which means that he optimally should have a high-risk, high-dose statin by today's guidelines. In 2008, he came back to me 3 months after his initial visit and had a heart attack. Again, he's 55 years old. He was given clopidogrel and aspirin. He was also given prescription of carvedilol, but he was started on a high dose of atorvastatin. And that brings up a point that there is problems with drug-drug interactions with protease inhibitors. So he was given too high a dose of atorvastatin. And just a reminder that atorvastatin or rosuvastatin can be used with protease inhibitors, but lower doses and monitor for side effects. Pravastatin and simvastatin are contraindicated. And another important point for him is that they found in HIV patients that the older risk calculators and even the new ones tend to underestimate HIV patients' risk for coronary artery disease or heart problems. And that's in part because HIV can cause a problem with increased cardiovascular risk. So now that I work with the FDA, we work a lot at creating drug labels, and they translate to what the companies can say about their drugs, what we feel is right to say based on our review of the data. And a good way to look at drug labels, which also have good information on drug-drug interactions, is by using the website on the link here, but essentially drugs@fda.gov, and you can get to this site and look at product labels. So if you were to enter the name of a drug such as darunavir on this label, labels for the drug would come on that sort of place, and you would click on it, and you would get a full prescribing information for a drug. And the FDA has worked tirelessly to try and make this more usable towards clinicians. Drug interactions are in Section 7 and sometimes Section 12 too. So this is where you would find drug interactions, and you could see in one of the tables that if you were to use atorvastatin with darunavir, you shouldn't use more than 20 milligrams per day, whereas the high-dose statin that's recommended is 80 milligrams a day. So in his case, he should optimally be on a lower dose of a statin. And to make this talk kind of fun, I made a way to think of the talk, of how I'll talk about cardiovascular risk and HIV, about sex, drugs, and rock and roll. And the picture to come in mind is the rock and roll of the 80s with the guy smoking, and also probably you would expect him not to be the most compliant patient. And to lead you in that analogy, sex, I'll talk about HIV, drugs, about antiretroviral therapy, rock and roll, kind of the bad things, bad activities that sometimes people choose to do, lipids in terms of eating high-fat foods, smoking, and retention to care, maybe not keeping their appointments. So this is a table with some of the clues we had that HIV patients have higher cardiovascular risk. These were various large databases where they looked at patients with HIV and compared them to patients without HIV. Judy Currier in 2003 used the California Medicaid database. Virginia Traint is a popular prominent name in the literature, looking at the Boston Partners database. And there's some other countries. This is a French study where they looked at a lot of patients with HIV compared to not HIV. And most of the U.S. studies show that the HIV patients end up having about twice the amount of risk than a patient without HIV with having cardiovascular disease. And they also have cardiovascular disease at a younger age. So this is from Virginia Traint, looking at the patients in the Boston. This is a bar graph showing the events of HIV patients for cardiovascular incidence rates versus non-HIV. And then this is events per 1,000 person years per age. And the light gray line is HIV patients. So you can see at most of the age cohort, age times, HIV patients have higher event rate of heart disease or cardiovascular disease compared with the dark black line, not HIV positive. Some information of what we've gleaned about HIV and the drugs is by a large database called the DAD study. It's actually a large cohort of patients that are followed, over 30,000 patients who are HIV positive from Europe, Australia, and the United States. And if you look at these patients, a higher portion have the risk factor of smoking, about 56%. They also have some diabetes, some high cholesterol, and some high triglycerides, and a family history of coronary disease. But the current smoking is kind of significant here. We know some things are non-modifiable. We can't modify how old we get. I wish we could. We can't modify if you're a male, because males tend to have higher risk for coronary artery disease at younger age. But there are some things that can be changed. If someone has high blood pressure, by treating their high blood pressure. If they have diabetes, they have bad habits in diet, you can definitely work at improving that. or patients can, if they have problems with their lipids or if they smoke. So this is a graph looking at different cohorts of HIV patients compared to non-HIV patients. And in this cohort, the age HIV cohort, and that's how they write HIV, patients with HIV in this dark black end up having more hypertension than those without HIV, and more diabetes mellitus compared to those without HIV. This cohort, which is a Danish cohort, looked at the patients with HIV compared with non-HIV. So the patients with HIV are on this side cases, and the controls are patients without HIV. Black means that they have more than one comorbidity, and this dark gray means that they have no age-related diseases. And you can see HIV patients, either younger or older, end up having 4 or more comorbidities more than those without HIV, and less patients on the flip side have no age-related disease if they're HIV positive. So that's part of the problem. Another problem is people tend to get fat with age and also develop metabolic syndrome. The diagnosis of metabolic syndrome are on the slide, various lab parameters and also the size of your waist. If you were to have metabolic syndrome, they've evaluated a test called this cardiac intima media thickness. It increases with the more components of metabolic syndrome you have. And people with HIV tend to have more so these central obesity phenomenon. And also it's been associated with problems with insulin and glucose metabolism, and that in turn is also one of the definitions used, the high glucose level. They also tend to have cholesterol that's more likely to cause heart problems and hypertension. And if you look at these patients with HIV patients with fat redistribution, they also had more cardiovascular disease than age-matched control. So that's one of the other contributing sort of factors that's going on. This is from the MAX cohort, which is a HIV cohort following HIV-infected men in 4 different cities, compared with HIV uninfected gay men, so it's MSM. And this is what happens to a cholesterol when someone has HIV. Given these natural history studies, they were able to study this. So this pre-seroconversion level is here for your various total cholesterol, LDL cholesterol, and HDL cholesterol. And these bar graphs are this dotted line here, slash line. That's what levels were back in the early 2000s, what your cholesterol should be. So ideally, your cholesterol should have been less than 200. Now, of course, they use this risk calculator. And your LDL optimally should be under 100, and your HDL should optimally be over 50. So in these 50 men who were not HIV positive, their levels were pretty good. Their LDL wasn't too bad, but it was above 100. When they followed them, when they ended up getting HIV, what happened is their total cholesterol declined, their LDL also declined. These both things are good. But their HDL declined, which is bad. And the way you increase your HDL is, of course, by exercising and doing good things, but it begs to differ. Once they get started on HIV medicines, their total cholesterol increased and their LDL increased, both bad things, and their HDL increased somewhat, but it didn't increase to the point where it was more protective, above 50. So thought is that something is going on with HIV that messes with your cholesterol level. If you're taking care of HIV patients, you know that there are many, many HIV medications these days, 28 plus, I believe, different antiretroviral agents, and the guidelines, the AIDSinfo.nih.gov have the guidelines, adult treatment guidelines that many people follow. Classes of medicine include the nucleoside analogs, the non-nucleoside analogs, integrase inhibitors, protease inhibitors. And these 2 classes aren't used commonly. There are also the boosters, ritonavir and covisistat, that are used. And I talked to Keely over the phone, and I remembered from my days in TDC and at Thomas Street that folks in TDC don't always get combination pills. But for many patients, even when they came to me at Thomas Street after being in TDC, they asked to be on the combination pills. So for some people, there are combination pills available, and those too have become more numerous. There was just Combivir, AZT3TC, and Truvada. Now, of course, there's TAF, emtricitabine, Descovy is the name of that. There's also 3TC and abacavir, known as Epsicom. And there are these single tablet NNRTI-based complete regimens and integrase-based complete regimens that are here. And some PIs have combined. Lopinavir and ritonavir, of course, has been around for quite some time. But within the last couple of years, we also have atazanavir co-formulated with cobicistat and darunavir co-formulated with cobicistat. So some information about what HIV does, and this phenomenon of inflammation that happens in HIV patients was learned by the SMART study. And the SMART study was where this was done in sort of the mid-2000s when patients, this was when HIV drugs were considered maybe causing more problems. People were more likely on protease inhibitors at the time than the newer integrase inhibitors that tend to have a better cholesterol profile. And the premise of the study was to either stay on your medications if your CD4 count is above 350 or stop your HIV medications. And then monitor closely if your CD4 count ends up being 350, patients were restarted on their HIV medications. And this study was supposed to have 5,000 patients, but it was stopped prematurely. It was supposed to go on for 5 years. After 18 months, it was stopped because those that stopped medications had more events than those that continued their medication. So major driving phenomenon was cardiovascular events. So I don't know where I put the mouse. Sorry, I just got... So if you look at those that end up having MIs or, So if you end up stopping your medications, the relative risk of you having progression or death was 2.6% than if you continued on your drugs. Now, for cardiovascular events, DC is if you discontinue your medications, and FVS is viral suppression, so that's when you continue your medication. There was increased risk of having these sort of things when you stopped your medications, and also when you aggregate having peripheral vascular disease, CHF, or coronary artery disease regarding medications too. That was significant, the difference. The numbers were small. And then also if you add on observed death, caused unknown, altogether, staying on medications was better than stopping medications if your CD4 count was above 350. Medications themselves can cause problems which make things complicated. So heart can affect lipids. Ritonavir and cobicistat tend to increase lipids. The PIs that were more recently developed after 2005, darunavir and atazanavir, are more lipid-friendly than lopinavir, which was used more frequently until the recent past. Integrase inhibitors and rilpivirine are lipid neutral as well. And TDF is associated with decreased cholesterol. And the next slides will detail some data. And these are sort of class phenomenons, except for the tenofovir and rilpivirine. So the lipids, in terms of class phenomenon, integrase inhibitors are more lipid-friendly than NNRTIs or protease inhibitors. And this is the registrational trials for raltegravir, first in the integrase inhibitors that was FDA approved to treat HIV. You can see the total cholesterol, LDL, and triglycerides. The colors don't project too well, but the first of the bars is the integrase inhibitor, raltegravir, and the second part of the bar is the second bar is the efavirenz. So all these things end up getting increased with efavirenz, whereas the raltegravir increases it less and the triglycerides are decreased. Now, increasing HDL, of course, is better for you, but altogether, the cholesterol profile is overall worse on efavirenz versus raltegravir. And like I said, the same is true for the other integrase inhibitors that have subsequently been FDA approved, that being elvitegravir, cobicistat as part of tenofovir and emtricitabine, and also dolutegravir. So tenofovir is also associated with the lipid-lowering effect. So this study was published in Clinical Infectious Diseases, where patients who, interestingly, were on monotherapy with protease inhibitors were randomly assigned to being on Truvada or placebo. And if you look at their cholesterol profile, you can see in the red box, the things that were significantly different were increased Truvada exposure caused a decrease in cholesterol, a decrease in LDL, and a decrease in HDL. Again, that was bad, but to a significant extent compared to them being not on a placebo. So Truvada is actually good, and that doesn't tend to hold with TAF, conversely. Now, triglycerides also contribute to HIV. High triglycerides have been shown to be an independent risk factor for cardiovascular disease. As I mentioned, nowadays, a way to predict cardiovascular disease is the statin calculator, that American Heart Association calculator. So there was a study done where they ended up doing actual catheterization, which of course is the gold standard of how to figure out what's going on in the arteries of the heart. And if they looked at patients with coronary artery disease in terms of having coronary plaque, those people, if you were to use the older guidelines, the ATP3 guidelines, which told us that was the category of 200, 150 as to using 200, your LDL level as a guide of when to start therapy, less of the patients, the lighter gray bar, would have been on statins even though they had cardiovascular disease on their angiography. Compared with the newer calculators in 2013, the ACC-AHA calculator, where about 30% of the patients with plaque in their coronary arteries would be calculators, but still not 100% of those people that actually had coronary artery disease by the calculators were to be on the statin therapy. So the DAD cohort that I alluded to before has brought to light data about maybe an association with certain antiretrovirals causing problems with coronary artery disease. The biggest news in late 2000s, published in Lancet in 2008, looked at abacavir showing increased risk of cardiovascular disease compared to other nucleosides. The FDA did a meta-analysis and found that in the totality of reviewing all these clinical trials on this slide, abacavir was not associated with increased cardiovascular disease. And there have been subsequently many other studies, many other cohorts evaluated for cardiovascular disease with use of abacavir, and the data has been plus and minus. So even though this large cohort ended up showing this problem with abacavir causing cardiovascular risk, it's not a definite reason why. And the thing against it is there's not a good biological mechanism why that would be. But there is some thought that maybe platelets in abacavir can cause problem with a platelet-related problem, which would lead to more coronary artery disease. But the concerns out there in the community. And more recently at CROI, which is the big HIV meeting in this year, 2017 in Seattle, in February, the DAD provided more data to suggest this time that darunavir-ritonavir may cause increased cardiovascular risk in HIV patients compared with atazanavir, which doesn't. And that's sort of things are highlighted on this slide with 59% risk increase per 5 years of darunavir-ritonavir. the mechanism for atazanavir causing problem, there has been a clue that maybe there is something with the hyperbilirubinemia that helps heart disease, and I'll show you some of that information in subsequent slides. So the next part of my talk is about surrogate markers and also various techniques we have to looking at cardiovascular disease. So one thing that's key is your CD4 being treated. So people with low CD4 counts less than 500 or less than 200, tend to have increased cardiovascular disease. And the thought is maybe that HIV untreated causes some problems with the immune system and causes inflammation that in turn can lead to problems with the heart. So it's important not only from an opportunistic illness standpoint to treat HIV patients with low CD4 counts, but also because lower CD4 counts themselves has been associated with increased cardiovascular risk. So some surrogate markers in other than CD4 count to think about lipid profile, which we've already sort of discussed, but other things that are being evaluated and thought about are some parameters, including C-reactive protein, D-dimer, and IL-6, carotid intima media thickness, and flow-mediated dilation, and also PET scan. So I'll just sort of lead you through some of these techniques that's being looked at. So in the SMART study, they looked at IL-6 and D-dimer, and those patients that ended up having more deaths had a higher baseline IL-6, high-sensitivity C-reactive protein, and D-dimer. And also those with those who stopped therapy, the IL-6 and D-dimer increased within a month of stopping therapy. This is a schematic from the New England Journal of Medicine as to what happens in a coronary artery when someone has a heart attack. So the A is a cross-section of the coronary artery. B is a little bit more what happens on a closer microscopic examination, but I'll draw your attention to C here, which is what goes on to cause your coronary artery to be clotted. So these are the endothelium cells, the T cells, things going on in terms of your T cells and in terms of your immune system, and bacteria and viruses play a role in causing these components to increase here and causing more thrombus. So there is something going on that from an immune system ends up causing more problems with more clot. One way to look at non-invasive way to look at atherosclerosis is by this carotid intima media thickness, and I did some research with this at Thomas Street when I was there. So carotid intima media thickness is an ultrasound exam that's done of the carotid arteries, which are in your neck. It's pretty easy to do, so I was able to do it at Thomas Street Clinic, where an ultrasonographer came to the clinic and did the studies. But there have been studies to report increased abnormalities in HIV-infected treated patients. It's usually been associated with traditional risk factors, so those with high blood pressure, those with family history tended to have higher carotid intima media thickness. And the magnitude of an HIV patient having increased carotid intima media thickness is like someone smoking. There are conflicting data that protease inhibitors may contribute to increased carotid intima media thickness. And a large study by the ACTG, where it looked at carotid intima media thickness, showed that atazanavir ritonavir compared with raltegravir and darunavir ritonavir was associated with decreased CIMT. And one thought is maybe the hyperbilirubinemia somehow plays a role in helping the heart. And now there's also the data from the DAD cohort that somehow show that maybe darunavir can cause problems with carotid intima media thickness. Cause problems with increased cardiovascular disease, I'm sorry. So this is a picture of what a carotid intima media thickness study looks like. You can see the little blue and red lines. But you put a ultrasound probe at the neck and measure these the small parameters here and see what happens with changes over time to evaluate if someone's coronary arteries are getting more inflammation to cause more narrowing. So HIV tends to do something as well. So Priscilla Sue in San Francisco has done a lot of work with carotid intima media thickness, and she evaluated the carotid intima-media thickness in patients who were HIV positive, not on HIV medications. So their viral load was undetectable. These are these elite controllers that were able to control HIV without HIV medications. And if you look at those carotid arteries compared to those, the CIMT in the carotid arteries compared to patients without HIV, they're more inflamed to begin with. And these other cohorts of patients, people without HIV, with HIV on heart, not on heart, with different viral loads, it tends to be more increased compared with those without HIV. So that's another clue of something going on leading HIV itself causing problems with cardiovascular disease. Another technique that's been used in clinical studies is flow-mediated dilation, where they put an ultrasound probe in the antecubital fossa area and look what happens once you inflate a cuff and see how the brachial artery dilates. And we've used this, I'm working with the ACTG on a study looking at methotrexate, and we had patients do the flow-mediated dilation. HIV infection may cause endothelial dysfunction, so their brachial arteries don't tend to relax as good as those without HIV. And there's been studies to show HIV treatment itself improves endothelial function. And initiation of antiretrovirals at higher CD4 counts is associated with reduced arterial stiffness. And that was one of the other, nowadays they suggest treating everyone with HIV with antiretrovirals. And one of the other things that helps, besides people staying healthy, not dying much, is also their hearts are healthier by doing that. And this is just a picture of what a PET scan looks like. And people with these patients with HIV compared to Framingham risk score matched patient had this increased sign on the PET scan. But this increased sign was also associated with the soluble CD163 level, which has to do with things in the gut being translocated. So one area of active research is that things in the gut also affect inflammation in HIV positive patients. So inflammation is kind of complicated, but many different ways we see inflammation happening in HIV patients that in turn lead to increased endothelium adhesion, increased monocyte activation, dyslipidemia, hypercoagulation, and thrombotic events or clotting in the arteries, and endothelial dysfunction. And the components that play a role include HIV production replication, the T-cell problems that happen with HIV patients, the metabolic syndrome, the CMV excess pathogens also tend to cause problems, microbial translocation, and also the antiretroviral drugs lead to problems too, to some extent, things like abacavir. So more is being evaluated in terms of what to do about it. So the HCTG is doing a large study with pravastatin to see what happens with the addition of pravastatin in patients. And as I mentioned, I've worked with the ACTG on evaluating if methotrexate is beneficial to decrease cardiovascular risk. We're close to evaluating the data about the methotrexate study. So I wanted to go back to the case and bring it back to the patient level rather than to the theory. So low CD4 count may have played a role in him. Remember, his CD4 count when I saw him in Thomas Street Clinic was 120 something. So that may have played a role in his increased risk. It's interesting that the new DAD data shows a possible association with darunavir to his cardiovascular risk. However, in this patient, I had limited information as to what his past history was in terms of antiretrovirals. So switching to atazanavir, which may have a lower barrier to resistance, might not be the right way to go in him. These days we could have also thought about giving him dolutegravir, but those are things to think about on the patient level. But for him, it was also this history of psychosis. So it took a lot of time to try and get him to take his medications. He saw me. He developed a relationship with me over many, many years, and also saw our PharmD in clinic. And actually, one of the reasons he came to me is another doctor asked him to change his medications, and he wasn't happy with that. Some people are very married to their medications. They don't want to change them. So you have to also work with the patient and other circumstances besides just what's out there in the literature. Patients have complicated issues. So this is a little diagram I made about unmodifiable and modifiable conditions that are contributors to HIV, to cardiovascular disease and HIV therapy. The unmodifiable stuff in the green, of course, you can't change, unfortunately, but you can change the things in yellow, the modifiable conditions. And to some extent, the lipids, the things in pinks, HIV and heart contribute to. You can do some things to try and alter that by medical therapy. So it's sort of complicated what causes increased cardiovascular risk, but you can work at decreasing certain things with your patients, and some of these are sort of challenging. Some of them are easy. Hypertension, give a medication, follow their blood pressure. So I was going to go to smoking, which is sort of complicated. In HIV patients, it's quite prevalent. In Thomas Street Clinic, 47% of the patients smoke. In the NA Accord, which is another large cohort, 46% of the patients smoke. Smoking is a large contributor to cardiovascular disease and to cancer. So there was a patient who came to me at Thomas Street and asked for help with quitting smoking, no history of depression. He asked about starting Chantix or varenicline. And just like in TDC, there were places that extra steps you had to do to get patients medications that are more expensive. So for me to get him Chantix, I would have to, or varenicline, I had to make an extra phone call. And so when he asked me, I have to decide if it's worth making that extra phone call. And there is data to look at different drugs in HIV-infected patients. Varenicline, the efficacy is 34% compared with patients having nothing over 12 weeks. And also over 48 weeks, it's a little better. But an interesting thing they did at Thomas Street was to use text messaging in cell phones. So they would send patients text messages, ask them about how they're feeling, setting a quit date, those sort of things. And folks at MD Anderson developed this text messaging system. And those people that got the text did better than those that didn't get the text. And they had to get standard of care, which was, everyone had to get standard of care, which is go to smoking cessation classes and have access to patches. And those patients who had the cell phone intervention did better than those without the cell phone intervention. So 16% versus 5% standard of care at 3 months. But the graph is sort of interesting. So after 6 months, you can see the cell phone intervention is the dashed line with the dark squares, and the usual care is the straight line with the circles. So at 3 months, it definitely showed a difference, but at 6 months, it gets closer to being the same, and then after time, actually the people who got usual care did better than those that got the cell phone intervention, which just is a clue of what is human nature, that, you have to make changes within yourself to try and quit smoking and sustain it. And fortunately, a simple thing like a pill or a cell phone text messaging for a short period of time isn't the answer. It's something you have to do on the patient level. So for my patient, when he asked me to prescribe varenicline, I didn't go against the grain and make the extra phone call because, it's a complicated process. I did send him to our smoking cessation program, got him patches, but I ended up giving him bupropion or Wellbutrin, which also in HIV-negative patients has been shown to decrease smoking, and that didn't require an extra phone call on my part. This is data at the recent HIV meeting of the NA Accord saying that those patients who had increased MI risk in HIV infection, if they did all three things, smoked, had hypertension and cholesterol, it contributed highly to patients having more cardiovascular disease and heart attacks. And 40% MI reduction was achievable through preventing smoking, elevated triglycerides, or hypertension, regardless of BMI. So they adjusted for patients that had a higher BMI. So if you can modify these things, it's good. And then briefly, I wanted to talk about retention to care. Now, this is a complicated thing to get patients to stay in care. There is the cascade that's well known that patients are diagnosed, not many patients end up staying in care. It's sort of a complex process. Things that can help patients staying in care include provider relationships, institutional resources such as outreach, and I did like the fact that patients in TDC had pill lines where you could make sure that they took their pill. Though I remember back in the day when patients had to take ritonavir, I heard stories of them throwing the ritonavir up in the air. David Parr once said, I think there was a bunch of ritonavir on a roof somewhere. Mental health services are definitely important as well. With my patient that I talked about initially, he had to go to psychiatrist to help him, and his patient relationship with me, I think, also contributed to him staying in care. Financial incentives is something that is being researched now. That, of course, is hard to sustain. And next slides, I'll talk a little bit about financial incentives. And cell phone interventions, like I mentioned about smoking cessation, has also been tried in different avenues. It tends to help adolescents or people that are tech savvy, but that too, there is an infrastructure sort of process that needs to be put in place. Although text messaging is actually pretty inexpensive compared to other things. So I tried to do a study looking at women after they had a baby to try and do text messaging in that sort of setting. And some women do like getting text messages. And for me, when I tried to do it, it only cost like 1 cent per text. So, and nowadays, even when I go to my doctors, I always get the damn text like your appointment is coming up. So that's not as expensive as some other things, but you do have to have an infrastructure to go ahead and do that. So one study to look at financial incentives I thought was kind of interesting. So this is HPTN 065, where they used many clinics, test sites in Bronx and DC, and they gave financial incentives to patients. So if they were linked to care, they got $25 if they got their labs done, and after they saw their doctor, they got our provider, doctor, nurse, or nurse practitioner, or physician's assistant, they got a $100 gift card with a development of care plan. And if they had their viral load undetectable, they got $70. And they had a maximum there. And they looked at linkage to care within 3 months and viral suppression. And not everyone did better with this financial incentive package. They compared it to other clinics that didn't have this financial incentive, and actually Thomas Street Clinic in Houston was one of the control sites. Patients that ended up, surprisingly, community clinics such as Thomas Street, you can see the p-value there, didn't do as good, didn't do any better if they got the financial, compared with patients that didn't get the financial incentive. Hospital-based clinics did do a little better, so maybe because it's a big infrastructure with less relationships, more ways to go. So something like UTMB might be one of those sort of principles, one of those things to think about where they did better with financial incentives. And smaller clinics did end up doing a little better with the financial incentives. But essentially, it's not as easy as $1. It's not as easy as a pill to get people to come to take their medications, unfortunately. And I thought it was kind of interesting. The only thing, I tried to see if this study was published, but all was published was this. So these are sort of qualitative studies, and I've participated in these studies before where they do focus groups and see what people feel like if they get the intervention. And they often talk to them and then put it in this computer program to see what recurrent themes are. And the title of the article is it makes you feel like someone cares if you get a financial incentive, which is kind of funny, but it's important to know. I think it's hard though to sustain that. Obviously, how can you give this sort of money constantly to patients, and you have to somehow get them to want to do it when the money's not there as well. So that's close to the end of the rock and roll journey. Hopefully I pasted for you. So I hope you gained an understanding of factors about cardiovascular disease in HIV patients, a little bit about the pathophysiology, the evaluation, inflammation. And it's important to note that the HIV patient population is aging, so they're more likely to get cardiovascular disease because of that. Antiretroviral therapies play a role. Lipids play a role, and there's ways you can modify that. Smoking can play a role, and there's some interventions that may help, realizing that it's a complicated process to get someone to quit smoking. And most people who've had to quit smoking or know people who have are well aware of that. Retention to care is something that is difficult and challenging, but there are no answers. So in terms of my rock and roll journey, I just put the characteristic that the hard rock 80s sort of person can be evaluated, changed to the more modern rock and roll. I know U2 is coming to town next week. I'm a big U2 fan, but they're more of the picture of a different sort of rock and roll where you can modify your risk factors and do things in a cleaner, better fashion than the bad habits of the 80s. Not that the 80s weren't fun. So I have a couple small challenge questions. So which drug has not been described as having increased risk of MI by the DAD cohort? I don't know exactly how to do the challenge questions in this format. Should I do there's only 5 people in the room. Should I do a show of hands or? Okay. So what is the answer? A, darunavir, B, abacavir, C, atazanavir, D, lopinavir, ritonavir. So I think everyone in the room got the answer, atazanavir. As we mentioned, darunavir, now there's new data to suggest that that may cause problem by the DAD cohort. Abacavir, that was done, that signal was elucidated a little longer while ago than the darunavir, which is just a recently described phenomenon. And lopinavir, ritonavir has been associated by the DAD cohort as well as causing increased risk of MIs. The next challenge question is HPTN 065, which was that financial incentive study, found that financial incentives can significantly increase viral suppression in community clinics. True or false? Yeah, so that was false as well. And that's it. These are my references. Thank you very much. I wanted to also acknowledge Natanya Ute at UTMB who helped me with some slides. Like I said, I'm at the FDA. I still have an adjunct of associate professor affiliation with UT, so I can be reached at either of these emails. And we're done early enough for a few questions. Does anyone have any questions? And I thank you so much for all you do for HIV patients in TDC. I know from being there that it's very tough to take care of patients in TDC, but I was always grateful that I was able to provide care and continue antiretrovirals for patients in TDC. Any questions? Okay, great. Thank you. Feel free to invite me back. Sure, you're welcome.